So somatostatin analogs are extremely important. They have two roles. They have the role to treat symptoms related to these tumors, because many of these tumors, they will secrete hormones, and we can control some of that with the use of somatostatin analogs. But it's also very important as a treatment in terms of controlling tumor growth. We know from the GEP-NET and the PROMIT trials that the use of somatostatin analogs as the first-line treatment in the metastatic setting or in patients with locally advanced disease delays the tumor growth of these tumors. So it's extremely fundamental for the treatment landscape of neuroendocrine tumors, the use of somatostatin analogs. So we typically use somatostatin analogs as the first line for patients, and the general consensus in the neuroendocrine tumor field, they are very interchangeable. So you start with one, and then when they progress, you should change classes of treatment. However, there is some interesting new data and retrospective analysis coming up saying that perhaps there might be a role to switching somatostatin analogs before jumping to a completely different class of therapies. We truly don't know that. For the time being, we typically will use one of the two commercially available somatostatin analogs as the first line, and then at the time of progression, if you're just doing that for tumor control and patients don't have any symptoms, then you normally will switch to a completely different class of treatment or intervention. But I'm very interested in this new data that's coming up, that perhaps there might be a role of sequencing even the somatostatin analogs per se. It's too early to tell. We will see when more studies come out.